Thank you, Chair, and thank you to Avtar and Dr. Jasujya for inviting me for this presentation. Now, vascular access surveillance has been a process which has been introduced a couple of decades ago when there was a pretty prevalent AV graft use, and it was getting clotted off pretty quickly, and many of those access thrombosis were being treated in the hospital, and the patients used to stay for days and weeks before they got some procedure done. So there was a need for identifying what access is going to clot, and at that time, the main reason was considered to be a stenosis. So I want to go over the whole process of surveillance took birth during that time period, but now since in the last 2 decades, the care has completely transformed. We have to kind of look in and what is the current barriers and challenges in, or should we, how the surveillance program should be around. So I don't have any major disclosures in this regard. We'll go over some definitions, and we'll talk about the needs of the surveillance programs in various aspects of the dialysis access life, different techniques, and its effects on hard clinical outcomes, not interim clinical outcomes like thrombosis. And also, we'll talk about a few therapeutic options on that. Now, this slide probably summarizes the complexities that we encounter in the access care. So it's very important to see the surveillance not in silo, but as part of a general access care. These are the number of people involved in the care. These are the number of processes which are involved in the care of the access, and you can imagine how difficult it will be to navigate through this. So we do have different types of dialysis accesses, and for this talk, we'll not be talking about surveillance related to the catheter and catheter-related complications, but mainly AV fistulas and grafts, and since we don't use too many heroes, so and even if you did use the hero, it will behave more like a graft on that. So what is the definition of surveillance? How would you define surveillance? It could be defined in multiple ways, but WHO in the public health arena defines it in a very long, kind of twisted manner, but ultimately it is basically used for an early warning system. That's what we are using in access care. We are using it as an early warning system to identify an access which could potentially get clotted. But what we have not incorporated in this surveillance programs is an impact on the interventions, because we have given a pretty much clean sheet to the procedures that we do. We don't really kind of quantify whether they have been effective or not in this regard. And having some specified goals. You know, when the surveillance program for the vascular access came into existence, the specified goal was for them to prevent the thrombosis. That was an intermediate clinical outcome that they were looking at. But now we have to move beyond the thrombosis into access life and access patency. So the whole surveillance program is based upon the premise that a 50% narrowing in the lumen of a vessel will rise the interaccess pressure or drop the access flows. That's where the whole program has been revolving around. And KDOKI does help you in measuring those. But the thing is, we have to be careful about what we are talking about when we call as a surveillance. Are we talking about surveillance, or are we talking about monitoring? Those two are not the same. In fact, it's the part of the same continuum, but they don't represent the same thing. Per the DOKI definitions, the monitoring is mainly what you're supposed to be doing on a daily basis with your patients, which would be physical examinations, using their lab parameters, dialysis parameters. But the problem is, in all this digital age, the one thing which is vanishing is our skills of physical examinations, and especially the staff who are actually taking care of the access on a day-to-day basis during dialysis. So that's where the critical part is with any surveillance programs that you want to introduce. But as far as surveillance is concerned, it needs some kind of a device used to measure certain parameters, whether it's the flow or the pressure. So the surveillance program can be broadly classified into a flow-based and a pressure-based. Among the flow-based, there are different ways you can measure the flow. Most of the data has been on the dilution technique of different kinds, whether you're transonic or Fresenius with ionic dialysins or hematocrit with the crit line. The problem with flow-based has been, it is a snapshot in time which is not being measured it is more of an intermittent measurements done at least a monthly or sometimes in bi-monthly and sometimes it's once in 3 months. So for 90 days, you have no idea what is going on, and if you're not paying attention to the monitoring process, then you're losing some golden time for intervention. But when you do that, it does impact the delivery because it does take away a few minutes from the dialysis, and for doing any kind of a volume measurement, it does involve some capital investments and human resources. Whereas the pressure-based, the Vascular is a completely automated one which measures pressures every single time the patient is on dialysis. But why do we even need surveillance, right? Why should we do? The problem is in the access care, you're completely working against the odds. You're being given a vein, which is not healthy even before they create a fistula. And then even when they create a fistula, nearly 40 to 60% of them don't mature. Even if you're lucky to get the mature, they're going to develop some stenosis. And if you don't pay attention to these, then the fistula attrition rate will be very high. The fistulas that you fought so hard to get and mature them, if you don't keep them open, then you might lose it, and your catheter problem will actually get worse. And the longer the fistula is used, it's going to have some other problems, right? You have the aneurysms, and we just saw one aspect of the catheter problem earlier, but what we frequently see is this arm swelling because of the central vein stenosis. So the complexities exist in a variety of phases, but the surveillance that we talk about most of the time is this second half of the access life cycle where you're clinically using that and it develops a problem and you want to identify that to prevent them from clotting. We went over this. You know, most of the surveillance programs are able to identify an access dysfunction, but to us to have an impact onto the access, we really need to look at the interventions, how they are doing. And you have to question, does all stenosis lead to a thrombosis? Or do we know that how the stenosis will ultimately lead to a thrombosis? There is still a lot of gray area there, what we know about in that area. And also we had to come up with some hard endpoints. Thrombosis is just an intermediate clinical endpoint. And the biggest thing that we do in surveillance programs is we believe that we can introduce one surveillance program to a dialysis unit, and it's going to work on every single patient who comes in, who are there, and who are going to come in the future. That doesn't work. The one-size-fits-all kind of never works, to be honest with you. That's because the stenosis is not in one segment or one area of a fistula or a graft. Right? You can have inflow stenosis and you have outflow stenosis. The symptomatology associated with inflow and outflow are different. Now, how can we expect one single surveillance program to do that, to pick up every single thing? If we assume it, then yeah, maybe, but it doesn't work that way. As showed by Dr. Testori, this is probably the only one which actually compared different surveillance techniques with relation to the site of the stenosis. And as you see, the inflow, your physical examination is probably an excellent tool to identify that along with the access flows. But if it is outflow, again, the physical examination comes into the picture along with the, for the outflows. Access flows were not that significant in identifying a good outflow stenosis, whereas the pressure-based surveillance techniques did have a role in that time period. So what do we want to do with the surveillance? As designed, it is shown to decrease thrombosis, mainly in many of the observational studies and in single institution programs, even like us. This is a data that we published about 8 years ago. This is a time interval of 6 months. And once we introduced the surveillance program, our thrombosis rate dropped. By 1.5 years, it was dropped by nearly 50%. But obviously, the number of procedures went up, and it stayed up, but it kind of plateaued, but it did not continue to rise up. But is this the truth? How about some randomized control trials? Do we have any evidence? Can we go beyond observational single institution to something more? Unfortunately, there have been a couple of meta-analyses in the last year, but most of the RCTs were done more than a decade ago, right? And how we do angioplasties, whether it's the stents, it's whether our drug-coated balloons, they're all changing now, and we don't know what's the impact of that has happened on the surveillance program. So if you go by the available literature till now, it doesn't favor, especially in the grafts. The available literature says that if you're using an access flow surveillance methodology, it may not actually decrease your thrombosis risk at all. Okay, in fistulas, it does show that it helps. This is with the grafts, and that's with the fistulas, right? The problem is, again, I do not want to overstress this, but we have to be cognizant that most of these studies in the meta-analysis were based in the early stages when the angioplasties or how we were treating this thrombosis was quite different. What about the access patency? Again, if you look at what is access patency, so somebody clots, you open it up, and how long it's going to keep it open over a period of time, whether you need more interventions or not, right? The studies looking at this specific thing, again, is very limited, and many of them are old. Many of them are single, small centers. The biggest problem when you're reading about the surveillance programs and the outcomes is the design of the study, whether it's the surveillance technique or the endpoints that they're using. It's quite heterogeneous. Sometimes it's comparing apples to pineapples or watermelons, you know. So the results are quite mixed, and you have to be careful. And we reported this in a descriptive analysis when we looked at, is it really worth doing a surveillance? Or should we just look at the clinical monitoring? So if you look at that, there is mixed results. It's not convincing that all the surveillance programs are superior to the clinical monitoring. Whether if you do identify a dysfunction, should we go for a wait and watch approach, or should we just put them for an intervention? Results are mixed. The biggest problem for all of them is because of what we said. These studies are very heterogeneous. So if the current practice is you identify a dysfunction and you send them for preemptive treatment before they clot, right? So is that a good option? Because it does cost money. If you look, this was a recent analysis, again a meta-analysis looking at both fistulas and grafts. In fistulas, it actually helps to do some preemptive treatment when you find a dysfunction. Whereas in grafts, it's kind of mixed, or probably not yet proven. Now, if you look at the access loss, that means from the day that we actually abandon the access. If you look at that as a hard endpoint, fistulas, again, it helps, but look at the authors for that 4 RCTs. 3 studies were from the same author. Maybe it works under that authors, but does it work in other places? Again, the evidence is lacking here. It's very important that we need to develop a multi-center trial, which we probably need about 850 to 900 patients to do this, a solid trial in this regard. So at this point in time, all that we can say is it might decrease the thrombosis, but beyond that, we cannot say what surveillance do. It was very heartening to see that there was a randomized controlled trial just a couple of years ago. After a lull for almost more than 10 years, somebody did attempt to do one. But again, the control group and the study group is kind of very not so crisp and clear. Both monitoring quarterly access flows, but the study group had quarterly and duplex flow. Now you're introducing not just a surveillance tool, but actually a diagnostic tool into this mixture. So I don't know if you can really go. If you go even with this study at 1 year, they showed that the assisted patency, that means after an intervention, how long they keep it open, was good in the study group. But the cumulative or the secondary patency was not significant. And at the 3 years, the curve started to open up. Well, the numbers are too small. They were never powered appropriately for this, but this is at least something somebody is doing. This is where the Avatar's initiative about relooking at this is very critical. We really need more data, more studies to look at how the practice patterns change and how the practice patterns can impact these surveillance programs on the access outcomes, and I'm really, really happy about what it has been looking at. One thing that we should all be cautious about is when we are introducing surveillance programs in our dialysis units, we should not become complacent, because the staff might be feeling, well, we have in surveillance, they are doing some really nice stuff. They can, it can identify the access problems. Now I don't have to look at the access. I don't have to do the examinations. Surveillance does not pick up complications like this. Okay, these things also lead to access loss. It may not lead to a thrombosis, but it might lead to an access loss if it's not caught in time. So surveillance is not the answer for every ill of the access. You really have to be careful when we are introducing the surveillance. The data is still out there. You still have to do more research. You still have to answer a lot of questions and revalidate some of the stuff which has happened in the past. Because if you look at the ultrasound surveillance programs, the duplex ultrasound programs, they never did that in a fistula. All the randomized controlled trials using a ultrasound surveillance programs, I'm not talking about the access flow, but the ultrasound surveillance programs were done only in the grafts. So there is still a lot of things which needs to be studied and looked into and found out about it. So when it comes to the surveillance, it should not be seen in silo. It should be looked at as part of the access care continuum. The access care itself has so many inherent complexities that we still don't understand the complete extent of the access dysfunction and the pathophysiology behind it. So in that regard, identifying the barriers and complexities of surveillance alone will not truly help us improve the access outcomes. Now with that, I want to conclude that once you develop a paradigm, it's very hard to challenge its validity, and it's very hard to change the paradigm. So before you introduce a paradigm, especially in a country like India where it is just taking up the birth, it's extremely important that we learn from the other limited knowledge in the other field or in the other countries and come up with something really which can identify those flaws and correct those flaws when you're creating the paradigm in this country. I really hope that we are more proactive in that regard. And with that, I stop and take any questions.